unable to make those decisions for themselves when they are entering hospitals. We try to fight involuntary commitment everywhere we can, but also understand that there are times that people are involuntarily admitted to hospitals. We want to maintain that the empowerment and the decision-making for ourselves as that happens, and we see Psychiatric Advance Directives as one of the best ways to do so. I am going to refer to them as PADS from here on in because that's a lot of words to say. But I will let our panelists introduce themselves, starting with Kaely, and then we'll sort of get into it, and we'll have a lot of time for some questions from you all. But I will say the one thing that we are really interested in is spreading PADS throughout our state and also the country so that everyone has access to one and creates one. But most importantly for us is also making sure that the healthcare providers see and adhere to them at every chance possible. So we are working on a couple of things there, and we're excited to give you some updates as far as what we can, and go from there.
Awesome. Okay. Thank you so much, Luke. My name is Kaely Whittington. I work as a training coordinator at Honor Run of Maryland. Quite a bit of a drive to get here, but grateful to be here. And I am a person with lived experience with using a Psychiatric Advance Directive, which I'll be sharing in a few moments about how this document saved my life. It's a huge passion area of mine that I think everyone needs to know about as an option.
My name is Matthew Federici. I'm the CEO at Wellbeing, Copeland Center for Wellness and Recovery. There is a QR code here to an e-course on this similar topic that is free. Prior to my role at our organization, which is a national organization that promotes peer practices, peer support, wellness practices, including peer-facilitated psychiatric advance directive groups, I have been an advocate in a variety of different settings trying to support people to use advanced directives and crisis planning to further empower and improve the quality of services that people get. So,
I'm Ryan. I'm the program manager for Wellbeing, Copeland and Recovery. And yeah, I live in Chicago, but I come to this, I work with Matthew and Kaely, and I've done a lot of stuff on this topic as well. I come from the perspective that this is about rights, ultimately, and I do a lot of training, a lot of group processing around the advanced directives and crisis planning. I'll pass it to you, man.
Hi, I'm Ian Rodgers. I work for the Office of Advocacy and Peer Support Services at OMH, and I'm coordinating the efforts on the state side to work with the Alliance to update the PADS and increase uptake of PADS in the state system and the community. So that's the perspective I'll be sharing today.
So you all may be sitting in here, or maybe a few people. Actually, let me get a gauge. Can you raise your hand if you've heard of Psychiatric Advance Directives? I would hope so. Okay. And could you keep your hand up if you feel like really confident about, I know what a Psychiatric Advance Directive is? Define really not. Then it's self-defined, just like wellness and recovery. But hopefully leaving here, we'll be able to have some more hands up in the room. So Psychiatric Advance Directives, let's take a look at what these are. And I've got a basic definition from here from SAMHSA, which says a psychiatric or mental health advance directive, or PAD, is a legal tool that allows a person with mental illness to state their preferences for treatment in advance of a crisis. We'll be diving a lot more into what that means, but before we do that, I want to tell you the story about how using a psychiatric advance directive saved my life. And what better way to tell a story than through some illustrations? So over here on this side of the corner, I've got a picture of my mother and I on my 18th birthday. 18 years old is a very big milestone in the world of legal rights documents, so I figured I'd include it. You might not be able to tell from that picture, but I was actually really annoyed that she made me take that, and I was trying my best to hide the irritation from behind the cupcake, think I did a pretty good job. But I wanted to include that picture of my mother because she's been a huge source of support and advocacy throughout my journey. The next picture I have over here was from my freshman year of college. I was being knighted as a Vanguard for the honors program at the University of Maryland Eastern Shore. And you also might not be able to tell, but in this picture, I've been using that smile to mask daily thoughts of suicide and hopelessness. The reason why I chose this picture is because it was actually my freshman year of college when I experienced my first episode of psychosis. That psychosis was really confusing. It was really difficult for me to understand. And ultimately, I ended up going into the hospital for treatment. Now, because of my symptoms and my experiences, the doctors determined that I was incapacitated or unable to give informed consent, which meant that a lot of decisions about me had to be made without me. And although some of those decisions were beneficial, there were a lot that really weren't. And there were a lot of decisions that were made that I still carry the invisible scars with me today. And as you can imagine, the experience of not having a voice and a choice in my own care felt extremely disempowering. I felt like I had been robbed of my autonomy and my dignity. I felt angry, I felt fearful, and any trust that I had had in the mental health care system was shattered by that experience. When I was discharged from the hospital, I stepped down to a partial hospitalization program where I had a whole lot more freedom. I was able to start making more active decisions in my care. I could go home at night, on the weekends. I actually got to bring my own lunch. It was really cool being able to have options with the food. And it was some of the best treatment I've received in my life. During that experience, one of the things that the social workers brought to my attention was a Psychiatric Advance Directive. And I didn't know it was called that at that time, but it involved two parts. So the first part was granting my mother my power of attorney. And essentially what that meant was that she would have the legal authority to make decisions on my behalf if I was ever back in a state where I was unable to make those decisions for myself as determined by a doctor. The second part of that process involved the staff talking to me about what are some things that I would want if I was to ever experience this again? What are some things that I did not want and things that I would not consent to in the future? And just that experience of them bringing this to my attention was so empowering and helped repair a lot of that damaged trust. Because from my perspective, not only did these healthcare workers want to hear what I had to say, they wanted to make an effort so that other people could hear me too if I was ever to be back in a time of crisis. Unfortunately, that did end up happening, but this time I had my Psychiatric Advance Directive. Now, when I had entered the next state of psychosis, it was a lot more extreme than the first time. And even though they were pumping me full of medication that was supposed to be helping and supposed to be making things better, I continued to get worse and worse. My mom was being told that I may be like this and I may never come back out of it, that I may need to be transferred to a facility with a lot longer and more intensive care. What they didn't realize was at the time, not only was I going through the psychosis, but I was also dealing with an infection in one of my organs. I did try to communicate what I was feeling to the staff, but again, because of my symptoms, it was just kind of written off as another mental health symptom. Now, my mother is not only an advocate, but she's also a registered nurse. And when I talked to her on the phone about what I was feeling, alarm bells started going off and she knew exactly what was up. So because I had given her the legal authority as my decision maker, she called up the staff really quickly and told them what she thought was going on and what labs that needed to be ordered. But they told her that those labs had already been done and I was fine. That wasn't the case. This was just my mental health. So because I had done that preparation in advance and she had the authority to act on my behalf, she requested to see those labs. And when they went to go find those records, they realized there had been a big mistake and those labs had never been done. Needless to say, I got started on a course of antibiotics very quickly, and who would have guessed that once my physical issues had been addressed, my mental health started improving, And all of those things that they told my mother about long-term care, about never coming back, about having to just be like this forever, none of that happened. And I genuinely believe that if I had not had that document there in advance, there's a chance that my voice would have continued to go unheard, that infection would have continued to progress, and it could have resulted in either a long-term hospital stay or resulted in the ending of my life. And so that document was the reason that I have the voice in the crisis, but it's also the reason why I have my voice today. So I've got some other pictures up here. Over in this corner is from a short film that was played at a legislative briefing where I was able to talk about the importance of uplifting peer and youth voices. And up here in this top corner was more recent, although probably can't tell by the hair, but I was presenting at NatCon a digital poster on Psychiatric Advance Directives. And if you'd like a copy of that poster, I do have the link. Come chat with me afterwards. I'd be more than happy to share. But with that, again, this is an amazing tool everybody needs to know about because it is a way that we can make sure that we keep our voices and that we can have our voices heard, even if we're in a state where we're not able to express that in that moment. So, I'd like to pass it on down to you, Ryan.
Thanks, Kaely. So I want to talk a little bit about this really great infographic that hopefully should just give us a little bit of insight around some of the benefits of psychiatric advance directives. And so ultimately what we want to do is we want to increase the voice that we have in our own care and the choice that we have. But when we are increasing these aspects, right, this voice and choice, what we're also getting is we're increasing community safety, cultural competency, coordination across systems, and education for supporters. I know that if I'm able to voice what I want for my care, and I have choice in that, my supporters are going to understand a lot better what I need in those situations, right? And they're going to be able to coordinate with those systems a lot easier, and my doctors will be able to coordinate with each other. And it's really important that we address these things because this is what helps us with that voice and choice. But also, we know that when we have that voice and we can choose the type of care that we want, not only does it increase these things, but it also decreases and reduces hospitalizations, criminal justice interactions, homelessness, and stress with family and supporters. I know that I've definitely been in situations where family and supporters, it's really stressful because nobody knows what that person wanted or needed in those moments. And so being able to have those conversations very clearly, having those documents, we can reduce that stress as well. And we also know that when there's more choice and there's more voice, we're more motivated in our own care, right? And so it also helps all of these intersections simultaneously. I don't know, Matthew, if anything you want to add to this, because I know oftentimes we do some work together, or Kaely as well, we used to also do some work with this.
Is there the ASAR or something?
I don't have that.
That's okay. That's fine. So, so part of this is part of the work that we've been doing at Dorsa Wellbeing is we've done it virtually because we got started during the pandemic. I'd love to see it in person. But we've been doing a co-facilitated, peer-facilitated groups that the goal of the group is to bring people together with lived experience. The goal is for people to understand that they're beneficial to do, they're important for us to do, and that people come out through the course feeling more ready and prepared to start to put one together. Kaely is an exception to my 26, 27 years of an individual that just really grabbed the opportunity. So I want to say that about 27 years ago, I was working at a community-based psych rehab agency in Pennsylvania area. And I was working I was in a group home and I was in an employment setting and they did a variety of different things. But at that time I was closeted peer supporter because there just wasn't an opportunity, and actually if you disclosed, people would shut you down. But I knew from my own emotional crisis and hospitalization, I was very fortunate to have a very great support system too. I was under 18, and so I had parents and friends that advocated for me. I knew my voice wasn't going to be lost, but without them, I knew I wasn't wasn't heard. But I had them to be at my side. So when I started working in the adult mental health later on, coming from my lived experience of knowing how much one can actually transform their own lives, and I found I really struggled with the fact that people were constantly going through emotional crisis and mental health crisis over and over again, and everyone was expecting, and including the other person, it's like you're all playing these scripts in roles. And I was like, no, we learn stuff when we go through there. We learn stuff about what helps and doesn't help, and no one's asking or checking in about that. So at this time, I think it was maybe Wellstone, Senator Wellstone was advocating for parity with mental health around advance directives, that psychiatric stuff should be there. And the CEO at that time supported me to start talking about and implementing for that agency how we could support people around advanced directive planning. And one of the things that furthered this for me was there was somebody whom I was serving who had health cardiac issues, and they ended up in the hospital in severe condition. And I was pretty good at connecting because, again, I was coming from lived experience, but people didn't know it. And so the sister contacted the agency and wanted to know what Matthew thought Jimmy would want, whether he would want life-sustaining support or whatever. And I was away, and I was kind of thankful that I wasn't put in that position. And so my advocacy to a lot of the providers was, sometimes you're the one that knows this person best, and people are going to, family members, et cetera, are going to turn to you, but you got to be careful. Like, legally, you don't want to be making those decisions. We need to find out what people need and what works for them before these situations arise. Now, I was also motivated from the sheer fact that, like, I refused to think that I was exceptional in the fact that I learned stuff from my crisis, right? The expectation for people, and I could see that the way we respond to people when they started having issues, we would say, are you safe? Do you need to go? And it was just like right into the hospital, and then people get in the hospital and they lose their voice and choice, and there's nothing they could learn from that. And so I began doing these workshops in-house, internally, at the agency, and it was the first time I really experienced the stigma that the people who were supposed to be helping had about the people. There was a resistance, like they don't know what it is that they want, they don't, a lot of they and them and othering, and it was really hard for me to continue where I really related to the people we were providing services to. It was like, no. I watched since then laws get passed, documents and trainings that go over the documents. Like, here's what you put. Choices about this, choices about that. However, a lot of people, because they've gotten so accustomed to services, a lot of people lost a lot of their natural support, or I would say real support. And, as Kaely illustrated, having an advocate to you don't have to. In many areas, you can just write out directives and get that witnessed and signed. But having a key supporter that doesn't have a conflict interest at your side. We placed a lot of emphasis on laws and training people about the document, but we're not really supporting people to prepare for the kinds of things that only they can figure out. How do I decide who's going to be an agent? So this is why we've really emphasized these peer groups environments where we talk about things you would want in a supporter and not a supporter. And those things are not the same things as who you might want to be your agent, not your agent. You may have supporters who are really good supporters, another person's a really good agent, right? Because an agent's got to be somebody, for example, we talk about, you really want an agent who's going to be available and reliable, right? You may have someone who's a great supporter, but they occasionally take travel and vacation, they may not be around. So we really emphasize a model which is about how to support people to take the time, get the peer support in the room to think about these things. So I also believe this is a subject that everybody should be included in. I've witnessed a number of people, and I know that at some point my advanced aging needs may place me in a home. And I know that there's a tremendous amount of psychotropic and medications being given to older adults in those homes. And I don't want to wait that long to say, no, sorry, I don't want. I've been down that path, not advocating for or against or anyone else, but I don't want psychotropics. I don't want experimental drugs, unless that you're talking about psilocybin or LSD, right? How many people here know, whether they've had experience or not, know they probably don't want electric shock therapy? Yeah. And this, I ask this to the general public, people who have never had any experience at all, and it's like, listen, you just might want to put in your advance directive that you know that about yourself, because I know you think you may never be in that situation, but you might, right? And then the next question is, how about research? How about experimental drugs? You know, that there hasn't been tested in the market yet, because guess where they test it on the market? Is on you when you lost your voice, right? I have seen and known in my own personal life that regardless of whether there's a law or a set document, that when you have your wishes in writing and you have an advocate and that's notarized, you already have a patient's bill of rights at any of these facilities. And if they don't know and they have no documentation of knowing what it is that you want, and now you're considered in their care and not capable of being communicative about your needs, then they have no reason to ask or do anything but what they think is right. But if you have it in writing and it's signed and you have an advocate there, now you have a case for why did you do this when you had evidence the person didn't want it? You don't even need psychiatric advance directive laws for that. What we need is more and more people to know that you're better off having advocates and in writing. But people need a lot of support to start thinking through some of it, you know, and to do it in a peer support environment, because they're heavy topics, right? Like to go through like what, you know, seclusion restraints. I mean, we put out a paper that just say, no, period, no seclusion restraints. There's evidence that you don't need to do that, but places do it. But to have that topic being brought up, it's really great to have that in a group of peers with various different experiences. And there's no better way to ensure that you're not unduly influencing a person's choice than to have a group of people who have different perspectives on those things. And I'll tell you, one of the best intended providers, therapists, clinicians, their best concern is that they don't want to be seen or influence a person's choice around these. So many times the clinicians and the providers are not in a good position to be promoting these. Peer supported group environment where all we're doing is facilitating people's perspectives. And the best way to get that discussion going is when your facilitators can give illustrations. So to me, this is a big missing piece to why in the 26, 27 years that I've been doing this work, it just hasn't stuck. Now, the other thing that I hope starts to happen, and I would highly recommend, is I call it the ding, ding, ding seatbelt thing, right? Because that changed a lot of behavior for a lot of people, right? We got laws, you gotta wear a seatbelt, you won't do it until the car harassed them and put it on. So my whole thing is, I think if we, electronic health records, which is a big thing, that like, basically you're evidence of this, right? That if it prompts whoever is reading you, if it prompts you to ask, do you have one, yes or no? That's how this is gonna get started. And then people have to do the self-advocacy. So we have this thing called ASAR, which is what I used when I was at that agency for our policy. It was called CareLink Services. And this was the model, and I summarized it in ASAR. Ask. Anyone who comes into the services, whether it's residential, etc., ask, do you have one? Yes, how can we support you with that document? Because when the crisis happens, we need to move quickly, make sure people have a copy of that. No? Oh, would you like to learn more about it? And I refer you to a group that can learn more about it. So ask, then support, then advocate. So when the time comes where it's relevant, there needs to be a policy or a procedure for advocating for it. Okay, where are the copies? Did somebody, when they took them to crisis service or dropped them off at the hospital, did someone make sure that a copy or the agent was contacted? So have a policy for advocating for the usage of it, right? Follow up. Hey, just want to double check our client, etc., is in your care. Ultimately, a lot of these providers in the community are going to get them, they're going to refer back, right? So it's in their best interest to call and say, did you get it? Just want to make sure, were there any issues that came up? So advocate, advocate, advocate. And then revisit or revise. So now it's after the fact. How did that go? Do we need to change anything? It's a simple framework for policies for those of you who expressed interest in how can you support this at an agency. ASAR is kind of the way to go. If you're a peer or person with lived experience, you know, I would encourage you, I would like to see that we build an infrastructure of trained co-facilitators all around the country that are leading groups in this. The first step is to start one on your own. I know that in my experience, one of the things that can get in the way is kind of all or nothing thinking. So for those of you who raise your hand, if you know at the very least you don't want ECT, don't overwhelm yourself with this. Go ahead and get that notarized, signed, documented, and get someone who says, yeah, I'll go to the hospital with you and make sure they don't do that. So you don't have to do all of the, because there's a lot in the forms and documents, like what treatment facilities you like and don't want, what are other, you know, supporters you want there to help or not help. There's a lot of stuff. We'll start with what you do know. You can always revise it and update it. Start there. You know, get connected with some of these other groups that are doing peer-led facilitation of it. Bring it to your program. Open up the discussion, and get people thinking about this. And I know sometimes the other barrier is people get hung up on, well, what will the law guarantee or not? There's no guarantees. If a treatment team can basically, if a doctor can say, if this was the commonly known practice for this issue, I had no other information, this is what I feel is the best course of action, they can override your advance directive. However, they have to defend that position if you have this document. You have a case that a protection in disability law can work with. They can work with that. And at least you're going to get better care because that doctor is going to think twice. Well, you know, if there's a commonly known medication for something and no one ever told them you have an allergic reaction to it, they have no liability. If there was a document that said you have an adverse reaction to that and they gave it to you, you know, now if something happens, they're going to have a hard time defending and they may lose their license.
And I think on that topic too, with when we're like looking at laws and legal liabilities, kind of like Matthew had expressed, there's still a lot of value in creating this document, even if you're at a state where the laws aren't quite there yet. So currently, there's about 27 states, give or take, in the country that have laws specific to written psychiatric advance directives, which we'll talk a little bit more about what the difference is between that and kind of like a healthcare agent. In most states, you are able to list some mental health treatment preferences in a general advance directive. And in almost all states, there are decisions that a power of attorney would make some decisions about mental health care treatment. But there are 27 states currently, approximately I should say, things change day to day, that do have laws specific to psychiatric advance directives, which kind of just falls under the umbrella of the term advance directives, just kind of a more specific. Laws do, of course, vary state to state.
I have a quick question.
Yes.
This is kind of when we're out. Is it similar like having a surgery and I was going under and they had everything I was allergic to for my mental health? They had a list of everything I've taken, all my medication and everything. And they asked my husband, because it was during COVID section, they asked him to sit in the car. They gave me ibuprofen and they couldn't bring me back. I was seasoned and I died. They brought me back. They did not tell my husband that I died on the table because they gave me ibuprofen.
I'm so sorry to hear that happened to you. That's
Well, then they brought him in the hospital and said that she was seized and I died and they brought me back. He goes, what did you give her? And they refused to tell him.
that. As far as on that, I can't answer specifically on the legal part, but what I can answer from like a just empathy and like a human perspective is that's really wrong that happened to you, especially putting that work into place to try to advocate for yourself before the surgery. So thank you for sharing that experience with us. And yeah, I got ahead of myself too with that point up there. But as I said, almost all states allow an appointed agent, kind of words power of attorney may come to mind, healthcare proxy, decision maker, whatever, vary state by state, to direct some forms of psychiatric treatment. And again, most allow some instructions to be listed in kind of a more general advanced directive. But as Matthew was saying, there's still so much value in listing this out, having these conversations, and thinking about this before.
And if they receive Medicaid funding, if the facility receives Medicaid funding, it doesn't matter what the state laws are, they're required to ask you to look at your advance directive. I think that sometimes is an overlooked component. Is there may be state laws, but then there's a federal requirement for Medicaid funded programs.
So we do have rights. We do. And yeah, it's really important just to kind of take that time to learn about what they are. Yeah, so thank you for adding that. Let's look at what different types of pads are. And again, this varies state by state, but in general, for the states that have it, an instructional pad could be one part. And that's basically information about treatment history and preferences for future treatment. Depending on what state you're in, some states have very loose form requirements, some states have no form requirements. For example, in Maryland, where I'm from, I could choose to list out kind of any preferences. It doesn't have to fall under a strict structure. It isn't required to be created on a specific form. There's a lot of ability to kind of make it work for what my needs are. I don't have children. However, someone who does have children, it would be important for them to list out who would take care of those children in that crisis situation if they needed childcare.
Or pets too.
Yes, also for pets, yes,
Yep.
because we really like looking at kind of like the holistic and every aspect of our life, not just looking at medication, ECT, therapy, but really being inclusive of what matters to each person individually. So the next form of PAD is agent-driven. Like I said, you may hear power of attorney, you may hear proxy decision maker, healthcare agent, but essentially this would be a trusted advocate of your choosing that you would appoint to make treatment decisions on your behalf if you were determined to be unable to make those decisions by, depending on the state, Maryland requires 2 or more doctors, but, again, depends. And the last type of PAD is both, which is what I have, and essentially that just means that I have the instructional, I have it written out what my preferences are, I have my mom named on my power of attorney, and those are kind of combined so that the instructional would take priority, what I have listed on there, and then my mother could fill in the gaps if there were things that I didn't list. Because my pad's only about a 10-page document, and there is a whole lot more of my life that cannot be fit into those 10 pages.
And just real quick, that is what New York's is as well. There isn't a specific, like you were saying, healthcare or Psych Advance Directive statute, but Psych Advance Directives do fall under New York healthcare proxy law, and we do have in our form both the agent and then the written instructions. So just for New York context.
In Pennsylvania, we have a specific psychiatric one, which I was not a big fan of because it separated it in some ways. But I actually have a living will, advanced directives, healthcare advanced directives. My wife and I do both. And I have multiple layers of this in there. And my lawyer was like, no, this is good. So I don't even use the Pennsylvania psychiatric form. I just use a legal context that's certified. It's a broad-based advanced directives, like what happens to our money, who's in charge of that with the kids. But then I also have people who make certain decisions around my health care. And I have, like my brother is an agent for psychiatric care. According to the lawyer that I worked with, is that's fine. So I think sometimes we put ourselves in these boxes like, oh, psychiatric, living will, do not resuscitate. But there all these scenarios can be planned for and written, documented, and you can support yourself. So.
and there isn't just one New York State pad like
Yes.
For psychiatric, there's more than one.
there are a
Oh.
number of different
I didn't know
pad forms that can be used across
Oh.
New York and nationally. There's the Bazelon Center pad. There's a few Alliance pads running around right now.
We're getting into ones
I
pretty
know.
soon.
Janian has a
But
pad.
which one is legal? Like in Oregon, we have one, and they haven't been into that.
Can we table that real quick?
Yeah.
Because I
Sorry.
did want to get back
Sorry.
to that.
Sorry.
Yeah.
But also a resource to add, just because, you know, we all may be coming in from different areas, as well as folks that we may want to tell about. National Resource Center for Psychiatric Advance Directives. It's a website that is a wonderful hub and starting place that gives you information about all of the states.
But they were out of date too. They haven't kept up. So some of the pads are actually the old versions. So you just got to check the states, okay?
Yes, exactly. It is not a substitute for legal advice, just like we are not a substitute for legal advice or consultation. So thank you for bringing that up. All right, so that was kind of our little overview. And I know Luke had prepared some questions to talk about. I'm really excited to hear more about New York as well, because this is kind of a new area for me to wrap my mind around.
I think,
I've
you know,
been informed on what I can and can't say. There aren't many limits on what I can say.
We're
good.
So what
Question away.
I think one of the first things to address Anne's point, I think the legality aspect of things. I think one of the biggest concerns a lot of folks have about PADS is what I write in here going to be accepted as legally binding for folks? And the answer is sort of mixed. As Matthew put earlier, you know, there's a level of, yes, some clinicians can still deny what is written in there, but if you have something written down that is able to be, that is seen by the clinicians, it is much harder for them to deny that if there isn't a very legitimate reason. I have spent, for apologies to all the lawyers who might be in here, but I've spent far too much time talking with lawyers about what constitutes legal versus not, and I think, you know, at the end of the day, one of the things that we have heard has really been most things that would be acceptable medical practice should be adhered to. There's only certain cases where, you know, if it goes against your typical medical practice that, you know, it will not be acceptable. For instance, I think the best example I've ever gotten is someone is in a crisis. The only thing that they write down is, I need to be able to smoke a cigarette in my hospital bed. And that one probably not going to be adhered to just because of the general fact that you can't smoke inside and also the health aspects of it. But when it's talking about, you know, this kind of medication has not worked for me in the past and I would rather utilize this medication instead, I think those are things that oftentimes clinicians even want to hear because often I think people forget that clinicians tend to be playing a guessing game. And they go with the most commonly used thing first, and then you sort of have to fail at one medication before you're able to get a second one or a different one. So being able to say that, no, I will fail on this medication, you should start with this. And, you know, for some states there is some things around fail first kind of laws, but this allows you to at least state that preference right away. I think one thing go for it.
Yeah, so one thing I wanted to touch on too, because I love that example with a cigarette, right? In the hospital environment, yeah, smoking a cigarette indoors, you know, probably isn't going to work. However, that's still good information for the treatment team to know because, okay, maybe you can't have that right then and there in the emergency room. However, there is nicotine gum, there are nicotine patches. Maybe you can be transferred to a facility that does allow smoking. So even though something may not be able to be honored to the T that's written down there, there is still valuable information and just communicating that, hey, this is my preference. So yeah, that was my point of view. Thank you.
I appreciate that. And I think one thing that, you know, even before we get into we can talk a little bit about New York, about what some of the things that we thought were really important to include in the PAD. But
thinking about that post completion of a pad for individuals, what do you do next? How is this, when you think about it in practice, how do you make sure it's adhered to, or at least, get it in front of folks? Like, can someone, one of the four wonderful folks here, talk a little bit about that?
Jump into that. So a couple of different things on that. First, if you choose to name a healthcare agent, they absolutely positively must have a copy of that document, and they need to have consented as well to take on that responsibility, because it is a huge, huge responsibility to take over and make decisions on someone's behalf. And just like I spoke about earlier, how it was traumatic for me to have those decisions made for me, I'm sure it was really difficult for the providers who had to play that guessing game, right? And who had to make choices that ultimately caused harm to me. So on that, with the power of attorney or healthcare agent, make sure that they have the copy. As far as getting copies to the providers, there are a couple of different ways you can go at that. So there are some digital ways that you can store this document, and I will give the caveat that do your own research, make an informed decision about what data you would like to have. Of course, privacy is a concept, and privacy in healthcare, data breaches, cybersecurity, these are all real things to consider, and it's up to you to decide if you feel that the risk outweighs the benefit or vice versa. So I use a platform called My Directives. This isn't an advertisement or an endorsement from my organization. It's just something that I've chosen, where I have uploaded not only my Psychiatric Advance Directive, but also my Living Will into that platform. In the state of Maryland, that is linked to a electronic healthcare exchange system and can be accessed in every hospital in Maryland. There are other electronic healthcare records that My Directives is also connected to. Whether or not the providers seek that out depends on case-by-case basis. I believe North Carolina has their own state designated registry as well. So that is one option. Another option would be if you have a therapist, if you have a psychiatrist, if you have friends you trust, giving them a copy of that document to advocate for you. And
My directives,
real quick, would you mind holding that till the end for me? Because I do want to get back. So the other thing with that too is it shouldn't just be on us as the peers and as the consumers to advocate for ourselves. Some of this pressure does need to be put on clinicians, crisis workers, to be asking, as Matthew said, to be asking and to be looking. So it's kind of a twofold on how to have that access. But again, it really all starts with awareness and having these conversations.
So I can speak briefly to New York. In New York, for the Office of Mental Health and the Department of Health, we have what's called Psyches, and it's basically a really big clinical data warehouse. It houses over 12 million individuals, mostly Medicaid data, but also behavioral health encounters. So in that warehouse, it can be used for a number of different things: population health, QA, quality improvement, quality assurance, words are hard, and also clinical decision making. And that is where PADS come in, because since 2021, I did find the answer. Since 2021, documents have been able to be uploaded into Psyches, and that includes the Psych Advance Directives. And there is a section in the clinical summary under each individual that has documents and plans. And so each clinician or provider who has access to Psyches and has access to that client's information can see if they have a PAD uploaded. And so that's one area, again, uptake is low, but it has been enabled since 4 years ago. And there are enhancements coming that I can speak about later when we get into it.
Can you talk a little bit about, is it My Choice?
Yes. So my choice is the consumer-facing version of Psyches. And so we have a web-based portal and a mobile app for both of those. And the My Choice app basically looks the same as Psyches, except as an individual receiving care, you can go on, see your clinical summary, see the documents you've uploaded, download the documents, upload new documents, etc. And so it's basically like your version of what the providers see.
Yeah, and I think that is critically important
Yes.
for us, because I think oftentimes, you can go to a provider to upload this, but being able to upload it yourself after it's signed and witnessed, I think is really critical to having that sort of self-empowerment. I will also just make a plug to be able to look at some of the things that are written about you. I think oftentimes we don't always know what the assessments have been, and making sure that you see that. And I think New York is great for being able to, display that kind of information directly to folks who are utilizing services, so that we can also see it for ourselves and know what's up there, what clinicians see when we enter a facility or enter a program, and also know and sometimes be able to dispute any sort of things that might be incorrect, or if someone accidentally uploaded a document for somebody else. So those are important things to note and continue to look at. I think one thing when it comes to storing digitally that we really want to see is being able to, if you enter the emergency room, getting that sort of, similar to what Matthew was saying before, that sort of seatbelt sound for the clinicians, to be able to say, that flashing red light, if it is on the screen, that says immediately, this person has a Psychiatric Advance Directive, you need to look at it before beginning any sort of treatment services. And that's something that we're really interested in sort of advancing as well. Another thing I'm really interested, because we started talking a little bit about the sort of role of peers and particularly training, but interested to hear from Doris Wellbeing and you, Kaely, about some of the training that you all have seen, and then Ian kind of thinking about what kind of training you all are hoping to see when we have finalized the new platform.
Yeah, sure. I'll get started. I think that, like I said before, I think people, the main thing is that there are some big questions, and this can be the beginning for people to start to even really think about that. And I know in other work that we have done in advance, just around self-management and recovery, that there's a key way that should be facilitated. And it's a combination of almost psychoeducational and support. But I think it's really important that people are trained to facilitate it in a way that upholds certain core ethics and how that happens, right? That we're holding space for people, and that differing perspectives are invited in. There are core things like we do need to know whether we're going to do, as Kaely pointed up there, do you want to do instructional? Do you want to do agent-driven or combined? And you'd be surprised when you put it out there. It makes a lot of sense. Some people say, I want just instructional. And just for people to be able to process that, it takes time just to take that topic alone and process it. And then we haven't even gotten into so many of the other things that need to be discussed. Medication, people's experience with medications, and and a big area of support that people need is around support. So in most cases, you cannot and should not have an agent as somebody who's involved in your treatment. For a lot of people, they need to think about that, and they may think, even myself, is like, God, it's the best person for this. I haven't talked to in over 2 years. We need to get together and have coffee first and catch up in our lives before I throw this on them. So there's a lot of planning that people might need to make outside of that. So we've been doing this in a co-facilitated format online. Really, the next step is then to do a facilitator training and start delegating that so that there's groups following a particular approach. One of the caveats is we're not providing legal advice, and that would be a disclaimer of the curriculum. And again, regardless of the different legal nuances, this is what happens before then. So, for example, there was a group in Texas, Rio Grande Law. They had hired a peer specialist very similar to yourself, Kaely. Somebody had lived experience, developed their own, had a little paralegal background, and they worked with this disability laws group. And their role was to help people get their psychiatric advance directives together and have the form. He went through the course that we're doing and he said, this is so necessary because a lot of times people come to me and they're not ready to do this form. He works on if people were to have such a group format to think about these things and then really start to put down their ideas, they would go to somebody like this gentleman who is a peer, and he would help refine certain things. Like he might say, you might want to word it this way, because when you state your preferences, for example, around treatment, if you have like a medical explanation for that, it's going to stick more. If it's just I don't like this, because as Luke was saying, that ultimately when it comes to get enforced, we do need to understand that the treating practitioners have a legal liability to do no harm and provide what what their field considers the best known practice for this. So they have to make best medical decisions regardless of what you say or not, because they can follow your wishes and still be liable if it causes great harm. So the more that you state your preferences, so you can see why it's important for a peer group to be able to sit with and hear the different perspectives and experiences. One of the things that what you shared in your story is the importance of, even if you decide to have an instructional plan and you don't have an agent, or if you do have a combined instruction and an agent, why it's good to have other people aware, because I think in your case as well, people overlook things that were there. And it was only because advocates and supporters of ours that stepped in and said, hey, wait a minute, let me see those lab results, right? Or what did you give them, right? That's where I think when your other question was like, after it's completed, what do you do? I think we want to have as much supporters as possible around this, because it becomes like a checks and redundancy type of system. So this is why I think the training is really important, that in responsible systems, we're creating the right support for people to really think about, not just throwing, here's the document, here's the law, go fill it out, right? I think it's also really important that we're not putting providers in the position to sit down and say, what do you want here? Because there's huge conflicts of interest involved in that, for one. And two, there's a historical dynamic where I'm not going to be as free to say some controversial things that I might need to say about treatments. Like, there's a huge imbalance of psychiatric medications in our system. I'll just say that. Again, not advocating for or against, but when you enter in that system, how many people are familiar with this? There's a huge, medications are the panacea for mental health, mostly, right? I very seldom see people go through the public mental health system, and it's like, hey, do you want to try all self-management stuff, or do you want to start off with medication? It's always medications first, and then we work from there, and we fight whether it works or not works for us. And so when you have a system like that, how am I going to openly, talk about I don't know if I want this drug anymore. I don't really know if it's worth 20-pound weight gain to just feel a little bit more stable, that is going to be hard to have with your therapist or other folks. But in a room of peers where it's like, yeah, I had that too. At the same time, in a room of peers, you're going to hear, yeah, that I need that. That is really important for me. And I think we need to hear those differing perspectives. You're only going to get that when there's a peer group environment. And I think that's going to take a commitment to a group dynamic. So you have to make the group dynamic, create a safe environment. And you're talking about 16 to 20 hours of coming together and going through all those components together. And that's an infrastructure that can be built. We've done it around other curriculums, and so stop there.
Yeah, I'll add it, then I'll pass it to you, Kaely. I think it's also really important in this process is because I know that I've been in experiences where somebody says something about their process that makes me realize, oh, I'm missing something. Like, oh, I never thought about that. Like the first time I thought about these things, I definitely thought like, medications, right? What worked, what didn't work. I thought about all the reasons why I didn't want certain things. But I didn't think about experimental medication. It was like later on that I had to think about those things. Somebody else mentioned it. I think also it's really important in those spaces to think about general crisis planning. I've lived in probably 4 or 5 states in the past 5 years. These things change state to state. We've mentioned there's 27 approximate states that have some kind of legalness here, but there's a lot of other states. So for me, it was really important to have general conversations around crisis because what each state deemed to be in the advance directive was different. And so being able to have those conversations with supporters who could advocate for my care was really, really important because then they were able to come in and say, actually, this is what's needed in these situations if it were to happen. But I needed to have general conversation about crisis planning as well within that because for myself, I recognized that I was moving and that legalness changed from state to state. So I think part of that process is, just being able to have those conversations around what happens when we're in crisis and having conversations around what works for people. We learn a lot from each other. That's the power of those peer crises. I'll pass it to you.
Thank you. And one thing too, I just think like the importance of these group conversations and these peer facilitated settings is just so important because as you guys said, like there are some things you may not think about and you may hear it from someone. For example, when I do trainings, my training is more focused on awareness on psychiatric advance directives and general information. With Doors to Wellbeing, they go a lot more in depth when they do actual like groups, kind of like that 16 plus hours. I've attended one and it was pretty cool. So yeah, just the importance of diverse perspectives, but then also another thing to address. PADS, you hear about these great benefits we've talked about, and you hear about how these things can be life-saving, and it's kind of like, okay, well, why wouldn't people be on board with this? That sounds great. However, there is some pushback, of course, from peers themselves creating it, because one, thinking through these things can involve thinking about really traumatic times or the potential of it happening again. But then also the pushback with clinicians that they fear of legal liability. And there was a systematic review. If you catch me later, I can dig through and find exactly which one. But it touched on group facilitated psychiatric advance directives and more specifically, I guess, the general content. And one really common pushback from clinicians was that they were afraid that people would use this legal document to refuse all psychiatric medication. However, in the systematic review, they found that that was very, very rare. I believe it was like less than 1% of the PADs that they reviewed actually contain that. So although some folks may put in there, I don't want any psychotropic medication, and that is their right to voice that. Others may, and more likely in these group facilitated things, may say, okay, yeah, I don't want this, this, and that because I've tried it in the past and it did X, Y, and Z, but maybe I'm willing to try this medication. Or maybe I'm willing to try this medication if my psychiatrist that's treating me agrees and signs off on that. But again, that kind of varies state by state on if they can do that. Another thing too, in the trainings I do when it's kind of a more zoomed out, just a general what PADs are. The main message that I want to bring home to everybody with awareness is you don't have to be an expert to start a conversation. It is as simple as asking somebody, hey, do you have this thing? And typically the follow-up question is either, or answer is either yes or no. What's that? And with that, you don't have to be able to answer every question. I definitely can't. I'm not a lawyer. And even with the knowledge that I have, it's not all encompassing. But you can point them to resources like the National Resource Center on Psychiatric Advance Directives. What was it? My Choice in New York. Doors to Wellbeing, the information they have on PADs. So really with training that I focus on, it's bringing that awareness to the general public and then kind of starting that spark, right? My roar from my experience in involuntary treatment to really bring these conversations to life and start that domino effect of advocating for our rights and the rights of others.
So I want to get a little specific on New York here,
Yeah.
Ian. Can you tell us a little bit about the training and what you all see as, once this new form is fully updated, kind of what the goals of potential
Yeah.
training would be for New York State?
So before we go into the future, I actually dug into our records, and it looks like the first cohort of peers was 125 peers trained on pads in April 1999. So I don't know how I have a paper copy of that. But, from the OMH Quarterly in December 99, but I found that. I was pretty proud of it. But we actually, and I would point, when you're talking about training resources, New York would probably point directly to the Alliance, because we have this cool contract with them on peer bridging and training. So we work really closely with them on training, not only around pads, but any number of things. But once we get this document more finalized, more concrete, the training will be multifold. I think it'll be training providers around uptake in terms of how do you access them on psyches, how do you get into psyches, and that'll be part of our project as well. But technologically will be a big piece, both client facing and provider facing. And then I think the biggest thing that, and I know one of the questions about this later, so this might be a kind of getting ahead of the ball, but access and equity stuff will be a big part of the training. We have a lot of very important access laws in New York. What I'm thinking specifically of is language access. All vital documents are required to be translated into the top 12 languages in the state, and so I think that is a key piece of it, but that can't just extend to the document, that also has to extend to training. And then the other thing is reading level. Again, you can make the questions in a form as simple as possible. The legal language can't really change as much. And so the training around that has to be as clear cut as possible. And so it really is, how do we adapt some of these really complex concepts like you all were talking about into accessible language, accessible content that people actually can use and dictate their care, because otherwise it's just clinicians making decisions for people. So I would say those are kind of our two big areas, the tech access and general accessibility.
Yeah, and just to, Jeff?
I wanted to, this is general rollouts of anything, caution to an overemphasis around the forms and the documents and and as I was sharing my early experience, you can chain providers on here's the form and here's psyches and all this stuff, but there's going to be a lot of resistance in their deep belief systems about this, and then they're going to feel put to task that they are for treatment plans.
Oh, absolutely.
And they're going to roll that. And they need the support too, because the provider should be the one leading what's going into that. But if they feel like now we got to do them, they're gonna co-opt that process to get it done. And I mean, I understand their pressure. And so the peer infrastructure, trained peers who can support that, so that when the providers have to do that and a person's not ready, they can refer.
Yep.
Also, that for several different health education initiatives, everything from HIV to diabetes management, having peers lead the awareness stage as well as the deeper dive is critical, because the people who are seen as a part of that community have credibility, validity, and authenticity, and so the uptake on it is going to be greater from that vantage point. What I wanted to say about that also was that so really putting the emphasis and training on the peer infrastructure to be available to support that is going to be more key than some of those other things, because it's like the cart and the horse type of thing. So the peers are going to have that credibility and kind of rolling it out to support it. And Yeah, and then it's going to help those providers and
Exactly.
that system when that time comes as well. Yeah, so I just wanted to caution that because a lot of times,
And to clarify, we're talking about planning trainings for the future, but trainings on pads have been ongoing for years and years from the Alliance. So it's not that this is a new project, it'll just be reinvigorated.
Yeah, and I think
so the Alliance has been training peers.
Yeah, what I will say is we are already considering some possible ways to revamp that training to have it be more inclusive but also more effective. And you guys might be getting a couple phone calls from us pretty soon.
so that now I'm remembering the other point about the cultural linguistic accessibility is also the most effective approach to that is when you have people who are from those communities,
Exactly.
people who are Spanish speaking bilinguals,
Yes.
are also the peers leading those groups.
Yes.
Then that's the most accessible because you also don't have to worry about the reading writing level
Exactly.
because the engagement is a verbal discussion.
Yeah.
And we can always find the support to have someone write it down. So that's where I think the peers from the authentic communities, so when we're training peers to lead these groups, also prioritizing folks from the right communities that are bilingual will, I think, resolve a lot of that. I've seen systems where they train providers, they get materials that are accessible in different languages, but without that peer component authentically down into the Spanish-speaking bilingual Black communities, it's not going to get hold.
That is also something I wanted to touch on too, and I'm unapologetically jumping ahead on this one. On the topic of cultural competency, this is such like a key part with Psychiatric Advance Directives because I don't know something about a thing I haven't experienced unless someone shares that experience with me. So there are things that I may miss. A really good example, and I believe Amy Detmer had shared this example. There was a person in an inpatient setting. She was a Black woman. They didn't have the proper hygiene products for her hair, so she wasn't able to groom her hair. Well, from a staff perspective, they're looking at, activities of daily living. This person isn't taking care of themselves. That's a symptom. But was it really a symptom, or was it that she didn't have access to the products that she needed for her hair texture, and that wasn't being picked up by staff who had hair texture like mine? Some other things too with language. So I had heard a story about a person who was Haitian. They spoke Creole. However, when they were in an inpatient setting, these providers were not familiar with Creole, so they're hearing words that they believe don't exist. However, he's speaking in his native language.
Right.
So that could be something put into a Psychiatric Advance Directive. I need an interpreter for this language.
Yeah, that's a great point.
And all facilities, and the rollout is complicated, but all our state facilities are required to have language access plans and interpretation services, and that includes Creole. There is a long list of languages, but it's getting there. So that's why we still have an Office of Diversity and Inclusion.
Yeah. We're happy you still have that
Yes.
office. Because I realized that we are getting close to time. Really quickly, just to know some of the things that we thought about for our update include, the medications you do or definitely do not want, the reasons why, medications you would want, the reasons why, situations where you might say yes to an experimental, or actually is ECT, and then codifying that and saying no situations do I want this, maybe some in this sort of explanation. I think the part about children, the state added back in, which was really helpful. And it has been a very, and the pets, and a lot of other aspects that, we took a lot of time to really think about it. We've been working with the state. I will be going back to do some more revisions in the next week or so, but we're really hoping to have something final by the end of the year so that we can begin that rollout for New York, and then begin really rollout for the new PAD form.
So we are updating
Who
the
are
current.
we? You say
Yeah.
we, who are we?
We was the groups of folks who, over the last 2 years, who had originally looked at the pad forms, provided some
That
recommendations.
doesn't make, who are we though? I mean, you
It's
said
New York.
Yeah, this is New York.
New
So
York, so it's your organization, other organization. We never heard of this, but I've been here for 2 years, so again, who are we?
So I think this actually really began 3 years ago with a lot of the legal and peer support folks who had provided some of those recommendations to make changes, and then we gave that to the state.
But
They're
you're
also
saying you're
responsible.
rewriting it, so we can come in now and look at the copy and work
Yeah,
with you?
yeah, we can
Okay.
we can take a look at that and then see if there's anything else that needs to be added. But I think the big thing was really about making it more accessible, easier to understand, and a little bit shorter than what was in the past. And now also looking at a short form version as
Yes.
well as a longer version that explains a lot more. But also wanted to make sure that, for some of the clinicians who might not read 10 pages, the biggest pieces are right at the front so that they know.
And it's a tool. It's really not the whole thing. It's not an IKEA assemble it together. Like you guys make the tool, but you don't even have to complete everything that's in there.
Exactly. Yeah.
And
You
it's
can also
not like
add
you're
things to it as
yeah.
well.
And you're not required to use that form. In most states, that's not the case. They're just like ingredients, and states develop forms as a tool, and everyone mistakes the tool for the thing. Like it's the ingredients. Ultimately, you have to know for yourself what you want to advocate for or against, and how you want to put that together. And I just want to caution because I see so many systems just obsess over the form. Yay, we're done. We got it done. We handed it out. Doesn't go anywhere.
I have a question. I'm a family advocate. I'm from NAMI, the National Alliance of Mental Illness. We teach classes and provide the trainings for family members, people with experience in mental health and all that. The biggest challenge, what I hear, is like the families are struggling where to find the resources, in the state resources. The county, yes, I've been in NAMI for like mental health like for 34 years. The county resources, I can give it from the tip of my head. But the state resources, is there a directory where the families can find the resources easily? It is a challenge for them.
Is this for New York State you're asking
New York
about
State.
broadly?
New York State.
And you're talking programs, you're talking ads,
The programs, okay, for example, I'm just going to give you a simple
Yeah.
example. One of the family member, their loved one is in Rockland Psych Center. Something is not going right there. So this mother is devastated and she doesn't know who to contact.
We have our customer relations line would be the first thing, and then the field office in that region would be the second.
Now, is
I
there a
can give you
listing where
those.
the families can,
Yes,
is there any way I can get that
Yes,
email?
I can get that to
Because we provide
you.
the resources throughout the county.
I can get that to you.
Thank you.
And there's usually, right, there's patient rights advocates embedded in each of these systems.
Correct, yes, and including Justice Center, but I think and we can talk a little bit.
The
about
list of
that.
resources, if I can have where the
That'd be
families can contact.
So there is a QR code that went around to a free e-course that you can take. It's not, to me, it's not the full thing, but it's a good course. It's about an hour-long course that takes you through the different components that we hardly scratched on today. But it also talks a little bit about crisis planning in general and the role of peer support. You can download that and check it out. It has been supported by SAMHSA.
We can also put this on our Doris Wellbeing table upstairs, if anybody wants to look at that later.
Yeah, people look at us for resources.
Yeah, yes, this would be one to just begin the basics. Yeah.
All right. Well, thank you all for coming today. I think there's plenty more that we could talk about with PADS. I think we can talk for days sometimes, but definitely if you have more questions, I know our panelists are typically happy to talk more about this and connect with happiness. And please reach out to us if you have any other questions for New York stuff, as well as OMH. But thank you. We're going to have our award ceremony and annual meeting in a little bit, but you got about 10 minutes before that starts. All right, thank you all.